So welcome to Grand Rounds, August 2022. This month we have Dr. Sharif Elnaggar talking to us about piriformis syndrome and does it really exist? Dr. Elnaggar graduated from Temple University with a Bachelor's of Science degree and a concentration in kinesiology. He then earned his Doctor of Physical Therapy from DeSales University, graduating with honors and receiving the Professional Excellence Award and Research Excellence Awards. He then completed his residency in orthopedic physical therapy at St. Luke's University Health Network, where he acted as chief resident. Since graduating residency, he's been practicing orthopedic physical therapy at St. Luke's and teaching about the diagnosis and management of lumbopelvic pain in the St. Luke's University Health Network orthopedic physical therapy residency, and also in the DeSales University Doctor of Physical Therapy program. And just as a point of reminders to everybody, please make sure that you sign in to EADS so that you can get credit. You then take the quiz and also the course evaluation. And I think if the quiz is not loaded yet, it will be by later today. So just when you go in, it only offers you the evaluation. Double check later today, and it should be active then. And if you're watching this on the recorded version, then just make sure you complete the quiz and the course evaluation because you're already logged into EADS. If you have any questions, please feel free to contact me and I'd be happy to walk you through it. So without further ado, I will turn it over to Dr. Elnaggar.
All right, thank you, Steve, and thank you everyone who is listening. So yeah, as we already mentioned, I'm going to be talking to you guys about piriformis syndrome today. So this is just the continuing medical education credit information. Designation statement here, as you can read. I have no relevant financial relationships to disclose. So what we're going to be doing today is essentially going through the etiology, current definition of piriformis syndrome, and then we're going to do a little bit of a dive into the recent evidence regarding this diagnosis, prognosis, and interventions for piriformis syndrome, and then we're going to go into differential diagnosis for individuals with buttock pain of a musculoskeletal origin, and then we're going to talk about treatment strategies from a physical therapist perspective to evaluate and treat individuals with buttock pain. And also provide evidence regarding this etiology and other potential etiologies for buttock pain. So we've all had this patient, at least at some point, who comes into the office and they have this somewhat non-specific complaint of pain that's right in the buttock area, and they can't really describe where it's coming from or what essentially has happened. They've said they've tried icing it, massaging it, doing different things, avoiding sitting on that side, but they just can't get it to go away. And this is where that relative diagnosis of piriformis syndrome came from. So in order to get into, firstly answering the question of does this exist, what it actually is, we're going to take a step back and just look a little bit at the anatomy of the piriformis here. So the piriformis itself is derived from the Latin words pirum and forma. So pirum means pear and forma means shape. So essentially it is a somewhat flat pear-shaped muscle that sits deep in the hip. So on the right side, you can see that the glute max is reflected, and you can see some of the other deep hip musculature there with the piriformis outlined. And then on your left-hand side, you can see that origin from the sacrum around S2 to S4, and then it runs through that greater sciatic notch, and it inserts on that medial aspect of the greater tuberosity of the hip. There's been some literature showing that it can join with some of the other deep hip rotator tendons when it joins to that greater trochanter, some of the gemelli there. But that essentially is where the piriformis sits within the hip. What it does do is that it actually serves as an anatomical landmark. So if you imagine here in this photo, that green image there is showing the piriformis muscle. And what's been most described, which we'll get into a little bit more in the literature, is that the sciatic nerve runs underneath that muscle. And you can see some of the other contents, whether it's inferior or superior to that piriformis, are getting their anatomical names from that. So superior gluteal nerve and artery, inferior gluteal nerve and artery, and some of the other, deep hip vasculature that runs in that area are also named based on that. Now, what does it do from a muscle action standpoint? We've mostly learned that it's a primary hip external rotator in the anatomic position. But something to know, especially about the hip, what makes it unique is that, one, we rarely are in this resting anatomic position. As individuals, we're moving often. And as we move into different positions, the hip muscles can change their actions. So something we've commonly learned is that the hip, as it becomes increasingly flexed, the axis of rotation actually changes, and that makes the piriformis become an internal rotator. So in addition to that, it does do some other things. Similar to the shoulder, where we have the rotator cuff that acts as a compression for the humeral head, keeping it centered in the glenoid, the piriformis helps with those other deep rotators that somewhat act as a cuff. When we put our limb in those single limb positions, it helps to maintain that neutral pelvis position and keeping that abduction moment at the hip. So again, another common research topic in regards to piriformis syndrome is variations of the sciatic nerve, which was first introduced by Beaton and Anson. And there's been a lot of studies since that time looking at different relationships of the sciatic nerve to the piriformis and actually different variations of the piriformis muscle itself. So this is showing on the top left. Firstly, the normal, what is considered normal, is that sciatic nerve passing underneath the piriformis muscle. And then the top right, it's showing divided sciatic nerve passing through and below the piriformis. In picture C, it's showing a divided nerve passing above and below. And then D, it's showing an undivided sciatic nerve passing through the piriformis. And E, it's showing a divided nerve passing through and above the muscle heads. And then F, it's showing an additional variation of a smaller accessory piriformis muscle within its own separate tendon. So getting to this a little bit essentially is if these variations actually matter and if that does, quote unquote, predispose somebody to developing this piriformis syndrome. Okay, so now that we've got a little bit of a background on what the piriformis is, what its anatomy looks like, the muscle action of it, the biomechanics, we can get a little bit into the etiology, the causes, signs, and symptoms of this syndrome. So it was first introduced in about 1928, and it was described as a periarthritis, so a generalized inflammation of the anterior sacroiliac joint. And then it was later coined in a paper by Daniel Robinson in 1947, and it was defined as a condition that's characterized by a combination of symptoms including buttock or hip pain, secondary to involvement of the piriformis muscle and sciatic nerve complex. When it was first established around this time, there was some different etiologies that some of the researchers had put in relation to piriformis syndrome. So what was commonly described is that individuals would sustain some type of blunt trauma to the hip, such as falling onto the buttocks, being in some sort of high velocity accident, something along those lines that causes an actual trauma, which led to some subsequent scarring formation, and that could have a cascade of effects such as hypertrophy of the muscle itself and other pathologies within the piriformis muscle, which led to the syndrome. So there's also other notions such as contractures or spasms of the muscle that can come for different reasons. And in addition, there could be a chemical inflammatory response of the sciatic nerve that could lead to some of the other symptoms. So some of the signs and symptoms that has been reported with the syndrome is buttock pain that increases with prolonged sitting. Most of the research says around 20 to 30 minutes. Pain typically is described as it starts a little bit worse and then gets better throughout the day. Some tenderness to palpation, an antalgic gait pattern, so you could see a lateral trunk lean or some type of antalgia. And any type of symptoms reproduce with anything that can put that muscle on tension. So now we'll get into a little bit of what the research has had to say about piriformis syndrome. So to start, it's mostly been case studies which have been published, and this is due to a couple different reasons. One of the first reasons is that it's difficult to control for something along these lines of piriformis syndrome, and there also has been a lack of a unanimous definition, a definitive diagnosis, and not a very high prevalence that's been actually recorded either for people who have been definitively diagnosed with this. So there's just not a lot of great research out there. There is research, but it's not of the highest quality as far as evidence goes. So the first thing we'll look at is the anatomical variation. So we talked a little bit about that with the sciatic nerve. This was one study by Nastis et al. In 2013, and they looked at 147 cadavers of Caucasian descent, and what they looked at was the anatomical relationship between the sciatic nerve and the piriformis muscle, and they used that Beaton and Anson classification. You could see that pretty much most of them followed the same normal anatomical pattern, about 94%. And there was really only 13 that had that different variation there. And the one that was most commonly seen was the common peroneal nerve passing through the piriformis and tibial nerve below what they called a double piriformis muscle. This was another study that was done where they looked at 240 cadaveric dissections, and again, they had 90% of these that had the normal anatomy, and the other 10% had some of those variations that were shown there below. So what they found in these studies is that there was no statistically significant difference in the prevalence of this condition between those who had the anatomical variation and those who did not. The other component is that most of the individuals within these studies had normal anatomy. There was more of a smaller population that had these differences. And a lot of what the findings have been utilized with more recent research is more so for orthopedic surgery if they were to do some type of actual intervention from a surgical standpoint, to be aware of if these variations exist and they were going to do some type of surgery. So still yet to be determined if these variations have caused any type of significant difference in the ability to get or be more at risk for piriformis syndrome. Some of the other things that the literature has looked at is imaging, looking at structural abnormalities, nerve conduction studies. So there was a couple of studies. This was Hughes et al. In 1992 and Nakamura in 2003, and they found some delayed responses of the piriformis muscle when the hip was held in that fair position, which is a flexion adducted and internally rotated position. There's a couple research studies looking at structural abnormalities. So this was a study that looked at the piriformis muscle itself. In two separate cases, they saw that it had muscle hypertrophy with signs of calcification around the tendon into the greater trochanter. There was one study in 2003 that found hyperintensity on a T2 MRI. And then also there was a larger study by Lewis et al. In 2006 that had 12 of 14 cases showing abnormal MRI. Suggesting some type of entrapment at the piriformis muscle. These are just some of the other operative findings that have been seen, some type of impingement between associated fibrous bands and the sciatic nerve, and certain bifurcations as well. So something that's also been looked at is injections. So there's been a couple of different ways that individuals have actually provided this as an intervention. This first study in 2021 was looking at CT guided injections and actually comparing if a Botox guided versus a non-Botox guided was more effective for pain relief. This study showed that the Botox was more effective, And then in 2004, there was one study that they used a visual analog scale before and after a local anesthetic was provided, and the pain response decreased by about 70% after the anesthetic was given. There is a place for surgical intervention in some situations if conservative treatment does fail, and the goal there essentially is to decompress the sciatic nerve and allowing for more of the excursion and mobility that it normally is able to have when it usually comes at a last resort. So taking all those things together, we looked at structural abnormalities on imaging. We looked at sciatic nerve variations. Are these findings significant? The big question. The one thing that was difficult to ascertain from the research is that some of the studies didn't even specify how long the follow-up was to compare pain levels. So when looking at the injection study and some of the other studies, the cadaveric dissections, some of them were 48-hour windows, which in my opinion is not nearly long enough for a long-term follow-up. Some of them didn't actually specify when the follow-up actually occurred, so there was no control from that standpoint. The other component to think about is it's been looked at and researched that nerve blocks that go distal to some type of nerve lesion can actually produce a pain relief. So is it that we're being very precise in providing this local guided injection to the piriformis and that was the cause of someone's symptoms, or is it just more of a local systemic response that is causing the decrease in pain? The other component is that do the so-called incidental findings that we see, such as hypertrophy of the muscle, inflammation, other types of findings that come up either on CTs, MRIs, are these findings in normal people as well, who maybe aren't experiencing piriformis syndrome, quote unquote, or hip pain? And this is just one study in 2014 that looked at as that prevalence, as we learn more and more about imaging of these quote unquote abnormal findings on the lumbar spine in healthy subjects. And this has been shown in numerous research studies as far as individuals receiving MRIs and having these, what we actually call normal age-related changes now, such as disc degeneration, spinal stenosis along those lines, and not correlating with actual, clinical pathology or increase in back pain or anything along those lines. So with all that being said, we have to take a step back and we have to look at, can one tiny muscle get all of the blame? So going back to that piriformis muscle, we need to ask, is that the reason for someone having the deep buttock pain, or do we need to reframe the way that we have thought about buttock pain and pay attention to all the other quote unquote loose change in the hip? So there's 27 muscles that cross that joint along with all the other soft tissues and everything that's running through that space. And this has led us to something known as the cocktail party effect, where the cocktail party effect, this refers to the ability to focus one's attention on a particular stimulus while filtering out a range of other stimuli. So you're at a loud party, there's music going on, there's a bunch of conversations, but your conversation with that individual, you're able to listen, understand what they're talking about, and ignore all of that other noise. And this is kind of what has happened with piriformis syndrome, where someone comes in, sit down, they say they got a deep pain in their butt, and we say, oh, well, it's your piriformis. That's what's going on. But what has happened a little bit more recently is that there's been a shift in clinical practice where an updated terminology for deep buttock pain has been introduced, known as deep gluteal syndrome, which has been defined as a presence of pain in the buttock caused by a non-discogenic and extrapelvic entrapment of the sciatic nerve. So this is that deep gluteal space. This is in the Journal of Hip Preservation Surgery by Martin et al. And this is looking at the contents within that space and also the borders. So just to orient, you have the piriformis muscle number 2 running across the top with that normal sciatic nerve running underneath. You have your medial border there of the hamstring origin. And you also have your gemelli muscles that are in the space, and then the quadratus femoris, which is just inferior to that. So again, this is just a list here for your reference of some of the contents that are running within that deep gluteal space. And this is another schematic that was given in that article as well that's showing. So you have the glute max as that posterior border. You have the posterior acetabular column as the anterior border. Medial border is your sacrotuberous ligament. Lateral border is your gluteal tuberosity. And then your superior border is the sciatic notch, and your inferior border is the ischial tuberosity. So there was an algorithm that's been somewhat broken down to help with the classification and diagnosis of deep gluteal syndrome. So somewhat similar to what you would see with quote-unquote piriformis syndrome is that posterior hip pain with potential radicular pain that worsens while sitting greater than 30 minutes. Tenderness in the buttock with some of these positive clinical testing that can be done. Imaging, which advances to two options of a specific EMG or local anesthetic. And then this classification of three principles: non-discogenic sciatic nerve disorder and some type of entrapment in the deep gluteal space. So this can kind of break down what actually can contribute to this deep buttock pain beyond just piriformis syndrome. So fibrous bands of blood vessels, condition known as ischiofemoral impingement, our hamstring muscles, the other deep hip internal and external rotators, and potential space occupying lesions. So to start, ischiofemoral impingement is described as a narrowing of the space between the ischial tuberosity and the femur. It's under-recognized, it's atypical, and it's been somewhat described as a hip pain that's been described after a hip replacement surgery from pinching of the quadratus femoris and the sciatic nerve between the lesser trochanter. So you can see here that if someone does have that ischial impingement, you can see they're having a little bit of that pinching going on between the lesser trochanter there and the ischial tuberosity, and that can lead to some of the similar signs and symptoms of deep hip pain with potential sciatic nerve involvement too. Hamstring involvement, something else, particularly more so if it is proximal, so higher up, and we know that those tendons are originating at that ischial tuberosity. So if someone's having partial complete hamstring strain acutely, and or if they have a chronic recurrent type of hamstring strain where you can start to have some changing of the quality of the tendon, and all of those things can predispose somebody to having some type of changes within that area, and can cause some entrapment of the sciatic nerve during hip motion. The other component to be considerate of is the pelvic floor. So this was a case report that was done on a marathon runner who originally was described to have hamstring syndrome, which is, again, that entrapment of the sciatic nerve as a result of some type of hamstring pathology that leads to some signs and symptoms consistent with sciatic nerve involvement that could, go down into the lower leg, starting up in that ischial tuberosity area. And what they found is they started some intervention for that, addressing the hamstring, and they ended up revisiting the patient about after 4 to 6 visits. They were doing things such as education, pain management, lumbopelvic trunk stabilization, glute max strengthening. But the patient reported that she was having pelvic pain that was persisting. So they then went into more of a pelvic floor exam, and they found a hypertonic disorder of the pelvic floor, and ended up addressing that by focusing on the pelvic floor, and that actually decreased the visual analog scale from a 7 to a 1. The patient was able to return back to running, and actually improved her sitting tolerance for greater than 2 hours. So this is just something to be considerate of in looking at a thorough examination and looking at regional interdependence, and making sure that we're not missing that. And if that referral needs to be made to someone who is more versed in that area as well. So getting to the signs and symptoms of deep gluteal syndrome, again, it's relatively similar to what has been described with piriformis syndrome, that intolerance to sitting, antalgic gait, and symptoms reproduced with some of those hip-related motions. So partly answered it before, but we're going to come back to that original question of, does piriformis syndrome exist? And I'm going to put a yes with a but there, and saying that it does, but it can be classified as a subgroup of this deep gluteal syndrome, but not all deep gluteal syndromes are coming from the piriformis itself. So again, going back to that loose change, we need to make sure that we're looking at everything else that could contribute to someone developing buttock pain in addition to just that muscle. So how do we get into the proper evaluation examination process? So firstly, anybody that's coming with hip pain, what we believe is hip pain, is we need to make sure that we're doing our proper screening of ruling out. So the lumbar spine obviously can refer symptoms into the hip area itself and even down to the leg, similar to having sciatica or radicular type symptoms. Looking at the sacroiliac joint and also ruling out any red flags, biggest of which being the sign of the buttock for the hip. So starting with the lumbar spine, there's three components here where if we're going to ascertain if the lumbar spine is contributing to hip symptoms, somewhat relatively straightforward, but still good to review. So essentially, if someone is having buttock pain that reproduces their symptoms they're coming in with, associated with back pain behavior and movement, and also with any type of spinal loading, such as repeated movements or any type of movements that actually load the lumbar spine. Some considerations to keep in mind as far as pain patterns is the radicular pain for lumbar. It often starts in that lower back, of course, can go across the buttock, and it may go down all the way into the foot there. It's not always described with deep buttock pain. If it's more of a stenotic type of pain, that mid to lower buttock region is where that pattern is going to present. And those are some things to keep in mind. If it's a central stenotic type of pain, that could be something that comes bilaterally as well. So that's also something to keep in mind. So the sacroiliac joint, unfortunately, we don't have the best evidence here, but we still should use our best clinical practice. And we want to make sure that we're educating patients appropriately and not, firstly, not over-diagnosing, but also giving them the right education when we describe how this is actually coming about and if somebody does have sacroiliac joint pathology. So the best way to look at this is to look at history and a lot of the subjective screening that's going to give you more involvement of if you should move your examination into this area. So particularly females, postpartum, other connective tissue disorders where somebody may have more movement laxity within that area. Looking at history, again, we talked about postpartum or any type of trauma that someone may have sustained. And then also with the signs and symptoms, someone may be reporting some feelings of instability or heaviness in the leg when they're trying to lift it. We can use when in the research as far as our clinical testing of the 5 tests, the distraction, compression, sacral thrust, those things to look at it as well when we move more into our examination. But these are some things that you can look at from a subjective standpoint if somebody's coming in to decipher if you should move in that direction before automatically just going to the deep buttock area or the hip. So in regards to actually going into the examination process, this is a potential algorithm you could start with, is looking at your gait and your functional movement exam. Based off of what you are seeing from those more gross movements, you can move into more of your deductive tests and measures based off that initial movement screen. and then delineation of the assessment findings once you are through more of the meat and potatoes of the exam. So some other things that I personally like to look at if someone's coming in potentially with some deep buttock pain, besides some of our more traditional range of motion, potential strength testing after we've screened and ruled out, is looking at the lateral step down test, a unilateral bridge endurance. So trying to get somebody to do a unilateral bridge with the opposite leg extended, and a failed test, you're either looking for malposition or offsetting of the pelvis itself, fatiguing, or reports that they're maybe feeling it somewhere else other than the glute area, so in their back, or having any reproduction of symptoms. Same can be said for the side plank endurance test, so looking at side to side. If it's too challenging for the patient, you could also do a modified side plank endurance test, and also just functionally looking at the squat, which can tell us a lot. This is one test that's been described to look at deep gluteal syndrome. I will preface it in saying that it is not a very good test to utilize. This was Fishman et al. In 2002 looked at the quality of this test, and it was compared to the H reflex, which is more of a sensitive test to measure for nerve conduction. And what to note about that is that this is not a gold standard for diagnosing deep gluteal syndrome. So they're comparing it to something that's not a gold standard. They did find a sensitivity of 88% and specificity of 83%. But because it's really only being tested to one thing and it's not a gold standard, there's not really high clinical value in this. But essentially, patients in side lying, you flex the hip, and then you're putting your hand on the pelvis and putting them into that adducted and internally rotating position to see if that reproduces their deep buttock pain. So we're going to get into a framework for intervention. The initial conservative treatments proposed for buttock pain was doing a lot of stretching, soft tissue massage, and other type of passive interventions, anti-inflammatories to try to reduce the inflammation in the area, and activity modification was kind of the initial treatments that were proposed. The question we need to ask is, should we be doing that? Should we be stretching somebody, doing massage, other types of active releases? Oftentimes individuals with buttock pain may say, well, it really helps to take the edge off if I do these things, if I work on stretching and other types of soft tissue work using a Theragun or something along those lines. And I like to tell patients that it's kind of like a leak analogy. So if you have this leak that's in the ceiling, you can place a bucket under it, and it's gonna catch the water, but it's not gonna, unless you go up there and figure out what's causing the leak, it's not gonna fix it. So if you do some stretching, if you do some massage, if you do some anti-inflammatory type of interventions, that again can catch that water, can help kind of take the edge off of your hip pain. But if we don't figure out what's actually going on, then that's not going to address your symptoms for the long term. So this is something interesting I came across, and according to studies, the average size of this muscle is about 2 centimeters, which is about the same size as a nickel. Not much bigger than the sciatic nerve itself, actually, which is quite interesting. And I myself thought that it was a bigger muscle, but what we need to ask ourselves too is that, are we highly accurate in palpating this piriformis muscle in isolation? So if you go back to the anatomy and you look at that big glute max muscle, biggest muscle in the hip, most powerful hip extensor, that's superficial to that. On top of that, you have all of your other deep hip musculature, your rotators, your other bands of tissue in the area. So if I tell somebody I'm going to palpate your piriformis and I'm going to do some type of active release for you, are we highly accurate? Maybe, maybe not, but just something worth considering and thinking about if you are doing that as a part of your either examination or intervention techniques. So the proposed way to look at your intervention from a physical therapy standpoint is trying to pay attention to the movement system and figuring out what again is causing that leak, that underlying cause, and that's going to give you those long-term results. And something that I've seen as somewhat of a commonality is this perception of tightness. And it's interesting that a lot of individuals, they say, they feel that their hip is tight, or you maybe put them into a figure 4 position, and you do maybe see that there is an actual difference from side to side. They maybe have more of a muscle length deficit or mobility deficit on one side versus the other. Is that actual muscle length tightness, or is it something that's been adapted over time? And that actual tightness is being something that's more of a weakness or a lack of actual motor control. And this was very interesting. There's a study I really enjoyed by Tonley et al. And JOSPT, and they looked at a case study of somebody that had this deep gluteal syndrome, this piriformis syndrome. And what they did is they proposed that again, a common assumption for physical therapy intervention for treating this is that this muscle is shortened, so you need to stretch it out, you need to lengthen it. But their proposal is that this muscle may actually be functioning in an elongated position and making it more subject to a higher eccentric load during functional activity, secondary to weak agonist musculature. So what they did was they tried to provide intervention of working on decreasing the amount of hip adduction and internal rotation, and getting more emphasis of hip abduction and external rotation, and seeing if that made a difference in this patient's symptoms. So what they actually did is they used this strap. It's called a surf strap, and it basically acted as somewhat of a tactile cue to help this patient focus on that hip abduction external rotation moment as they were performing a step down. So they looked at this before and after, and you can see that joint angle is a little bit more in that closer to 90-degree on the right versus the left when it was initially done on the left, showing that this did actually make a difference. Now, they did some other interventions as well beyond this, but it did somewhat support that notion that beyond more of the initial interventions that were proposed as far as working on muscle length and stretching, is if we can do some motor control strengthening for that hip complex, that is a good alternative as well. So this is a proposed somewhat progression that you could look at as far as motor control interventions if we're working on the hip musculature itself. So something I like to start with is isometric holds. There's been various literature that's looked at it, but if I can, I try to get somebody to hold it up to 30 seconds, even longer at a time, and doing low repetitions of it, which has looked a little bit at the primary motor cortex having a heightened response, which helps with our motor output. So if we can get more of that activation there, then that may help before moving, especially if you see somebody that really is just having poor activation when you're looking at strength testing, and the ability just to even activate those muscles that you're asking for in the hip. So once someone demonstrates that they can do that, you can progress more to these open chain isotonics, more so to fatigue. So having someone actually go through the range of motion, and then introducing more of your closed chain interventions, and finally going to single limb dominant, being that final step. So something to consider when you're working on trying to start, when you're looking at where to start before going to something that the patient may not be ready for as part of the intervention there. This is a hot topic in the PT world as far as if the clamshell is. I feel like every clinician I ask has mixed reviews. Some people love it, some people hate it. I don't really find that there's an in-between. I think personally that it is a good exercise when it is indicated, but I think understanding the reason you're using it and to make sure that you're using it for the right reason. So what I initially learned is that it was best thing to work on for the glute med, for the gluteus medius muscle. And what's been looked at in more research is that this actually may not be the best exercise for the glute med itself, but it does help for activating the glute max and glute med while minimizing the activation of the TFL. So if your goal is to work on abduction, external rotation, and getting more motor control and strengthening for the hip abductors and external rotators, glute max, well, if you see someone's really overactive of their anterior hip musculature, particularly the TFL, this, in my opinion, is a good exercise that you can use. But there are other exercises that actually get more activation of the glute med. And this was a study by Boren et al., and they looked at about 22 different exercises, and they found that the best one was a side plank with hip abduction, which is a fairly challenging exercise. If you haven't tried it, I'd challenge you to give it a go. But when raising the top leg, the leg that is down, stabilizing that pelvis, that glute med is the one having the highest activation. And you can see right underneath of it, the second highest EMG was the same exercise, but the leg that is up in the air. So just something to think about in regards to if you're really working on glute med intervention, if you do decide to do any type of clamshell exercise. It actually showed that the internal rotation clam was a little bit better for activating the glute med than the traditional one. So beyond that, from an intervention standpoint, what else can we do as far as education goes? Something we probably all commonly do, but it's just to make sure that we talk about aggravating factors and activity modification. So I tend to see this in a lot of people who have sedentary jobs where they're sitting at a desk for a while. So, I do educate if they are able to get a standing desk by any means, or they're able to take frequent breaks, just because that prolonged sitting is one of their driving aggravating factors. And if we can help with that in the initial process of when we're first seeing them, that can make a big difference in addition to what we're doing. We talked about more of the active versus passive interventions. I do still think that there is a time and place for those passive interventions if it does help somebody move better. But I think it's important that we establish and tell these individuals that we need to make sure that we're conveying what's the primary issue that's causing you to have this deep buttock pain, and make sure that we're addressing that as well. And also talking about ensuring that we're delineating a reproduction of symptoms versus exercise-induced muscle soreness. So there's more studies and more cases that are discussing whether pain thresholds can be used within rehab, particularly more so for chronic tendinopathies, hamstring, Achilles, lateral epicondylitis, where having some sort of reproduction of symptoms is okay within a pain threshold. But also educating individuals, if we're working on these hip exercises, what to expect from a muscle-induced soreness perspective versus their particular pain. So when they return in the clinic, they're not thinking that they're taking a step backwards, or what we're doing is actually causing more harm than more good. So to close here, I think the big takeaways is that we should understand that this piriformis syndrome, it's still, there's an unclear definition as to exactly what it is and a clear definition, but we do know that it can be a cause of buttock pain, but it shouldn't take all of the blame for deep buttock pain. We should look at utilizing the movement system as a guide rather than looking at a definitive diagnosis in isolation. Consider this underlying muscle weakness as a perception of tightness in individuals with deep buttock pain. Make sure that we're doing our proper education on active approaches, and also ensuring that optimal interdisciplinary care and understanding when referral may be warranted. So thank you guys very much. I'll turn it back over to Steve, I believe, and then if anybody has any questions.
What questions do you guys have?
Oh.
So one question that was asked is, with respect to the injection studies, did they mention how they diagnosed the patient with piriformis syndrome? Was it imaging or clinically?
I believe the two studies were with guided imaging first, and then once they saw that, they did the local injections.
All the people are typing in. This is great talk. When you see a patient and you address the movement disorders, and you feel, what would make you send them to a surgeon for potential surgical intervention for piriformis resection or something like that?
Probably similar to other patients where you've seen them for, I mean, I guess more classically, you may hear like 4 to 6 weeks. If someone's very highly irritable, maybe after 3 weeks, and I'm seeing increased symptoms of particularly like radicular symptoms, and if I'm seeing any type of like lower quarter changes as well, those would probably be two of the biggest for me. If I'm seeing that they're having intractable symptoms that's not improving with the active interventions we tried, and if they've already had other conservative approaches, from a medication standpoint, those kind of things. Obviously any red flags that you see, but if I'm seeing someone, maybe within that, if it's 2 times a week, like 6 visit window, and they're not having any type of response and are potentially having worsening symptoms, that would be my reason to refer.
And what have you seen as far as the literature on surgical outcomes from a functional standpoint, not necessarily surgical outcomes from a reoperation and infection level, but from a functional return?
The couple that I looked at, they had good outcomes, but again, they weren't like long-term follow-ups. So, I mean, I think one was like 6 months, the other might have been like 3. And there was, the biggest thing was, again, that's which you could argue correlates to function, was like pain change. It wasn't so much as long like, changes in like functional status, those things. So I didn't see anything that significant.
Okay. Thanks.
You're welcome.
What other questions do you guys have? All right. Well, thank you very much for attending, and please make sure that you check in later for the quiz. Make sure you log into EADS so that you get credit for joining today. Do make sure that if you're on this live that you take the quiz within the next week, because it will only be active for a week. After that, you need to take the recorded course. If you're taking the recorded course, excellent, you're already logged in. If you have any questions, please feel free to contact me. Thank you, everybody.